Hey, what's up, Canada and beyond? Welcome back to part 3 of our Doctor Talks. This has really been an overwhelmingly informative series. I am so thankful to have so many experts and so many of the real people standing up and on our behalf for, common sense answers, common sense solutions. If you guys can remember back just a couple of weeks ago, this whole thing kind of started with an interview with Dr. Bradell, who was part of the team that had challenged Doug Ford and their chief medical officer to a public debate to discuss the COVID measures and the impacts and all of the different things that the public wants answers for and did not feel that they were getting from our government and establishment. So without further ado, I'm going to bring on our next guest. Welcome to the show today, Dr. Tenenbaum. You come from a little bit of a different take in all of this, but I am really excited that we've had just a moment to get familiar behind the show here. And welcome to the show. Tell the people a little bit about who you are, where you're from, and how you end up here with me.
Well, thanks for having me. It's a pleasure to be on. I've heard your other shows, and they've been very informative. How do I get here? It's a really interesting story because my background is somewhat different. My professional training, of course, is in periodontology. However, I also have a PhD in cell biology, which I obtained during my training, and studied inflammation and bone cell biology, pain, and so on. And so this led me over the years, past 30 years, really to realize that the research that we were doing is biomedical research. By all intents and purposes, it really doesn't matter what your clinical specialty is when you talk about the type of research one does. And so recently, or over the past couple of years, we actually realized that many of the sort of mechanisms and therapeutic targets that we were looking at in our research that is related to inflammation and destruction of tissue, which is exactly what happens in COVID or COVID-19, were identical to those that happen in oral inflammatory diseases, particularly something called periodontal disease or gum disease, periodontitis, where you see destruction of not soft tissues like lung, but destruction of hard tissues like bone, caused by various processes, various enzymes and molecules. And they're the exact same molecules and enzymes that cause damage in the lung and other tissues in the body in patients who unfortunately develop COVID-19 and in whom it becomes quite serious. So we realized that the therapeutic targets that we'd identified might be important. In fact, we now know are important for management of patients who have COVID-19. And I would say to you that the best way to look at this is that we're not focusing so much on the virus causing the disease, although that's clearly important, as is its growth and replication. But what seems to be even more important is how the human body is responding to the pathological insult caused by the virus. Now, for example, in my field, in periodontology, we have people who are losing bone around their teeth. They're developing abscesses, infections, pain, and so on. And this is caused in large part by a bacterial insult. And of course, in COVID, it's a viral insult. But the bacterial insult in periodontal disease leads to all sorts of self-destructive effects in the body.
Well, now this is where this is it connects to some of the other doctors and specialists and scientists we've been hearing from this week, in where there is a lot more to all of this than what we are hearing from our chief medical officers. Yesterday, Dr. Alexander spoke to the correlation of obesity and nutrition and some of these things, and so this is again where we're starting to see and understand a little bit more of the micro comorbidities that are affecting all of this, and this is a kind of, I guess, the direction which led you into all of this is through your decades of research and studying and seeing some of this, and this is science and stuff that is so important, and this is why I'm highlighting on this, is that your expertise is extremely in depth, and this is information that is important to the situation and discussion that we're in.
Well, right. When you mention obesity, I have been trying to lose weight, so I hope you're not talking about that. But
no, I'm in the same boat.
Okay. But, interestingly that you mention obesity. As it happens, obesity is a comorbidity of COVID-19. Guess what? It's a comorbidity of severe periodontal disease as well. So is diabetes, a comorbidity. So you see that there's a tremendous amount of overlap in terms of just even comorbidities. But as important as that is, the underlying mechanisms that cause bone destruction and soft tissue destruction, for example, in any part of the body are important insofar as COVID-19 is concerned. And let me refer specifically to the fact that when somebody is suffering from acute respiratory distress syndrome, which is really what kills people in COVID-19, along with vascular damage and microvascular disease, it's a vascular disease as well as a respiratory disease, is the upregulation of destructive enzymes, which are called matrix metalloproteinases. I'll just call them MMPs. And yeah, I don't want to say it too many times in a row either. And the upregulation of MMPs, these enzymes cause destruction of tissue in the body. In the mouth, it's bone, which is hard, it's mineralized. But in the lungs, in patients who have acute respiratory distress syndrome as a result of COVID, it literally breaks down lung tissue terribly. It almost liquefies lung tissue.
Wow.
One of the other mechanisms that plays a very important role in periodontal disease is upregulation of something we call oxidative stress. Oxidative stress plays a central role in manifestation of inflammatory disease, and in particular in COVID, that's well known, and in ARDS, or acute respiratory distress syndrome. So oxidative stress plays a very important role in this. Well, wouldn't you know it, oxidative stress plays a role in periodontal disease and COVID. Both these enzymes that I talked about and oxidative stress, which is caused by molecules that we call reactive oxygen species, for want of a better description, are produced by the same cells called neutrophils. And these white blood cells, they're white blood cells, invade, in our case in the mouth, but in COVID, they invade the lung tissue. ARDS, or acute respiratory distress syndrome, is a neutrophil-mediated disease. And these neutrophils begin to spill out excessive amounts of these MMPs, excessive amounts of reactive oxygen species. And both these contribute to the so-called cytokine storm, and ultimately to destruction of lung tissue, and ultimately to destruction of distant tissues should the patient also develop more severe form of ARDS, which is a multi-system disease. So what are the therapeutic targets then? I mean, I've talked to you about them. What can we do about them? Well, this is where I started to get involved. We know from work done by my colleagues in the States, a fellow by the name of Dr. Lawrence Golub, who's a Canadian, but works at SUNY in New York, and co-investigators and colleagues also at SUNY who studied acute respiratory distress syndrome in clinically relevant models of this disease. We know that we can use an antibiotic called doxycycline to inhibit the activity of the very enzymes that break down lung tissue, the MMPs.
Right.
And that is the entree, really, that led me to start to discuss the possibility of looking at the use of doxycycline at various doses, particularly on compassionate grounds and people who really are on their way to dying, if you will. And I was met with utter silence on the other side by anyone I mentioned this to.
So
at one point, I was actually told, why would anyone want to do research on this particular issue just on the basis of a theory? I must have missed that lecture when I did my PhD about doing research on the basis of a theory. But anyway, nobody wanted to investigate it. Nobody even wanted to try it on people who were about to die. They'd rather stand by and watch somebody die. As Dr. Peter McCullough would say, it's nihilistic medicine. And there are now many reports in the literature. In fact, one of my favorite ones is just a case series. There are bigger studies, but this is my favorite report of it's only 5 patients, but they all had lung cancer. They had developed severe COVID disease. They were dying. And the oncologist who was treating these patients knew about doxycycline and decided to give them doxycycline because they were dying. Mm-hmm. They turned around within 2 days. One person took a little longer because he was much more ill and had many more comorbidities. They all survived by being treated with doxycycline. And I remind you, that's not necessarily because we did anything to the virus, although, as it happens, the icing on the cake, doxycycline interferes with replication of SARS-CoV-2 as well.
So, there's one of the things that you were talking about there. I'd like to back up just a moment and address in the production of these MMPs and being a process of making people with creating further lung damage. Are you seeing any correlation in any age demographics with this that are more susceptible or that are perhaps less susceptible to this theory?
I don't think because of how COVID has developed over the past year in terms of age stratification and so on, there really hasn't been enough time to look at, for example, different levels of oxidative stress or different levels of MMP production in different age groups. But what we do know from clinical studies in patients who have acute respiratory distress syndrome from flu, for example, which the end disease, the ARDS, as we call it, is the same whether it's flu or COVID, more or less. And those patients have been shown to have very elevated levels, typically elderly patients, because those are the ones that were studied over the years with influenza. And they have elevated levels, markedly elevated levels of these destructive enzymes. And they also have significantly elevated levels of oxidative stress and inflammation and infiltration of these white blood cells that cause this disease, these neutrophils, which spill out all these damaging molecules. Don't forget, neutrophils are very important. They're lymphocytes. They're important cells for protection against disease. But if they become hyperactivated, as happens in COVID and in periodontal disease, then they can actually start to do damage. It's a double-edged sword, the good, the bad, and the ugly, as it were. So they're protective, but if they become hyperstimulated, they actually begin to damage the host. So what we have developed in collaboration with Dr. Golub and others is this concept, really not that outrageous at all, called host modulation therapy. We're treating the host. We're trying to prevent the host from damaging him or herself by modulating the host. And I might point out, and this is extremely important, that this type of treatment is completely unaffected by any of the mutations in the virus. The virus itself is almost, I can't say it's immaterial, because in some cases it turns out we might need different combinations of these drugs. By the way, it's not just doxycycline.
Right.
Obviously, you've heard of ivermectin, hydroxychloroquine.
Yeah.
It's a multi-drug treatment that works very well. Doxycycline, when supplementing these treatments, it helps them even more. But the bottom line is that the virus can mutate pretty well as much as it likes, for now anyway, as far as we know. And this treatment is unaffected by viral mutation. Now, that's something that you can't say when it comes to specific antiviral drugs that target certain enzyme complexes in the virus, or quite frankly, even vaccination, when you're just targeting the spike protein in particular. It can change as much as it wants, but we're throwing a monkey wrench into the host machinery that makes the virus, and the host machinery that literally kills the host. That's what we're doing.
This is a consensus that I'm hearing so far from every expert that I've heard here, is that we're messing with the wrong stuff. Most of us have a basic understanding of how our immune response works and what an autoimmune issue is, where the system goes overboard and starts to attack you. So these are things you're speaking about here that we understand and we grasp. And what I'm hearing out of this is there's an incredibly promising treatment angle or path to look at from this in treatment versus vaccination, which most of us, I even hate to use that word at this point in time. I was never an anti-vaxxer, and I'm probably still not, but I am absolutely anti-experimental in what is going on here now. And I'm far more interested in treatment and progress and promising things of treatment than I am in what I'm seeing and hearing from the other side of the fence. And then what I'm hearing from you is you guys have found this, discovered this, and you're getting crickets.
Yeah, that would be nice if it was just crickets. In some cases, it's locusts.
And I kind of did it that way so that you could expand on that a little bit.
Yeah, but I wear it with pride. Having said that, you have to consider that this is it's a different paradigm. It's a different model to approach COVID-19. It's a host-focused approach. As I said, it's insensitive to viral mutation. It involves multi-drug therapy. Obviously, we don't treat HIV with one drug. And so doxycycline was my entree. But of course, we also know, based on tons of studies, meta-analyses, there's data out there that is being completely not only ignored, but dismissed by people for reasons that I absolutely cannot explain. Well, maybe I can explain it, but I don't even want to think about it. But there's lots of data available to show that a host modulation approach and an antiviral approach that uses cellular mechanisms of the host or blocks cellular mechanisms of the host to stop viral replication are probably going to be far more effective. And the studies have demonstrated this. There's studies that have shown people taking this type of treatment without doxycycline, doesn't matter, ivermectin, hydroxychloroquine, for example, 75% reduction in risk for developing COVID-19 in healthcare workers who are treating COVID patients. Why is that being ignored? And worse, why is it being dismissed?
I think it's even gone beyond that, as evidenced by the soap opera of the Ontario College of Physicians and Surgeons in the past 2 weeks, and their public statement, which they have now retracted. Actually, yesterday they did an about-face on that, and have publicly stated that they will no longer interfere with physicians willing to criticize lockdown measures and this kind of stuff.
Yeah, I'd like to know when in history any of the licensing bodies have ever interfered with legitimate diagnostic thought and recommendations made by physicians in this case, or other clinicians. I don't think there's any record of this in history. And I also think that one of the huge mistakes that are being made right now, and I'm not an epidemiologist, but after doing 30 years of research, I can read scientific papers. And I absolutely do not understand the application of the use of, for example, methods like lockdowns, which have never been used before. Where in history have we ever locked down healthy people? This has never been done. And the knock-on effects of this lockdown are going to be experienced possibly for the next decade or so. Locked in sequelae, locked in disease that hasn't been found or diagnosed and treated. Patients, we even see it, I'll even use, be a little bit dental here for you, if you don't mind.
Oh, but, hey, this is your platform today.
Yeah, we're seeing people coming into our hospital in Emerge, for example, who have problems that could have been avoided. Space abscesses that interfere with breathing. I mean, these could be deadly, or space abscesses or other abscesses that could cause brain infections that kill. Pain conditions, other treatable conditions that they were afraid to even come to an open clinic to get treated, because all we hear all day is fear. One of the fear mongering. I had a medical procedure done the other day, and I was in the waiting room watching one of the TV channels, the 24-hour news channel. It was 90% fear mongering, and 10% traffic. And I don't know why they reported on the traffic, because there is no traffic because of the lockdown.
This is exactly why this little series that we've, or this journey that we've embarked on, is so important. For the longest time, people were struggling to find anybody who was willing to give answers, and I was watching, and doctors were being terrorized as much as the regular public, and I could see the level of it wasn't just censorship and dismissal; it was blatant, all-out attacks, in career impacting measures being levied against doctors trying to speak to what they believed in. So when I first heard about this group that had kind of banded together, I reached out, and I think we're seeing a huge shift in the narrative, because people are not, they're going around the censorship, they're going around the mainstream media, because they recognize that too. It's nothing but fear. I spent 15 years in fire and rescue. I recognize trauma, and I see trauma walking down the streets holding hands with each other. They are terrified. If they see somebody on the sidewalk, they cross over to the other side of the street. I see a kid in a grocery store who, if you see somebody in the aisle, he's got his back pinned to the shelf wall. That is trauma. That is programmed trauma, and it's not going away anytime soon. The collateral damage that is going to come from all of this, including the lack of treatments, the despair, the mental trauma that's going on, is unfathomable to me.
Well, I couldn't agree more. If you think about this, as adults, we are currently being exposed to an environment of fear. Hopefully when all this passes, I would presume that most of us will recover. Maybe some of the people who are currently walking in parks wearing masks won't recover, but I presume that most of us will recover. But when you talk about a 5-year-old child or a 4-year-old child or younger who has been brought up looking at people who are wearing masks, being forced to wear a mask, being made to be afraid of their friends, being made to be afraid of interactions with other people. This represents what, 50% of their whole life? 60% of their whole life? For me, it's maybe 5%, not even 5% of my life. And so you're dealing with a person who has literally been developing their brain, their neurological system, their personality, everything has been developing for 50 to 60% of their whole lifespan under these conditions. Are they going to recover?
No.
Now, I'm not a psychiatrist, I'm not a psychologist, I don't know. I'm just asking the question.
And it's a valid question, and I'm not either of those specialists either, but I've worked with so many over the years, and they refer to something called imprinting, and it's, you know, by the time what we learn up until the time we're 7, that's stuck with us. So anybody that's, you know, from 5 to the age of 7 right now, this is going to be imprinted on their brain that if they don't do this, they could kill grandma and grandpa. And that, to me, is a travesty. And that's just one demographic. We look at the teenagers that are turning 12, 13 years old. They've just endured 4, 5, 6 years of all of this. The world is ending, climate crisis. And now this, why bother? Why bother living? Right? What is there to live for?
Yeah, we have seen several-fold increases in contacts to suicide centers and so on. I've heard it said that suicide is down in Ontario for some reason. I don't know how the data were generated, but there's plenty of anecdotal evidence from people who deal with this particular issue, including emergency responders who have a very different story to tell. But again, this isn't my area. However, I think it's a rational question to ask. And as you have pointed out, you've spoken to people who are experts in the area, and this kind of confirms my concerns. But getting back to my area, we know that we have treatment based on this concept of inhibiting or stopping the host from recreating or replicating the virus, of stopping the host from destroying itself and therefore surviving the disease. Especially if you treat them early enough, you'll prevent hospitalization, you'll prevent death. But why are we not doing this? I mean, I think I can say, and I think if you spoke to most of the people in our group and other experts from around the world, like Harvey Reisch from Yale University, Peter McCullough from Baylor University, I think they probably agree with me in that if we were to implement this type of treatment now, we could end the pandemic now.
I completely agree. In my past experience, I've been involved in other task forces where we were tasked to challenge the government to improve treatment options versus some of the options that were out there, particularly in the field of cancer detection and cancer treatment. Prevention is far easier than treatment, and the science is moving faster than industry, and the government likes to control things that they can control the money in, and they're really not interested in some cases for expedient treatment or expedient prevention over treatment.
Right. You know, it's fascinating. I've often said to myself, I think George Orwell was an optimist, to be quite frank. And can you imagine any other disease? What about community-acquired pneumonia or bacterially acquired pneumonia? Can you imagine anyone saying to a patient who was diagnosed with emergency, let's say they diagnosed an emergency with pneumonia, they took a radiograph and they found, oh yes, there's some condensation in your lungs, you've got pneumonia. Go home until your lips turn blue and you can barely breathe, and then come back and we'll think about putting you on an antibiotic. Could you imagine that happening? I can't. And yet, this is precisely what we're doing with this particular disease. And if there was no available alternative treatment, then I guess I could understand. But there is. And the literature is absolutely chock full of evidence to prove that this treatment is safe, effective, and as it happens, inexpensive.
So where do you think the divide comes in the ethics and practices of medicine out there in all of this? Because I mean, we are seeing such conflicting opinion, and this type of crisis and situation should be based on science and evidence, and this is not what the public is seeing.
Well, I don't understand really what's going on with my medical colleagues. This, by the way, you see this in all professions, that
Yes.
people deny the certain realities because it may interfere with certain beliefs. I really just can't understand it. I can tell you a recent anecdote, which was, this is first person really, or second person, I guess, from somebody in this consortium or research consortium that I deal with. One of our members spoke to a specialist in infectious disease, and she said, if I developed COVID-19 and I was getting sicker, would you treat me with ivermectin or hydroxychloroquine or one of these treatment regimes? And the doctor said, oh, absolutely not. He said, I mean, there are papers that show, the papers that showed that hydroxychloroquine was effective and safe, those were withdrawn from the Lancet and the New England Journal of Medicine. He's talking about these two infamous papers where, in fact, the exact opposite happened. The papers claimed to show that hydroxychloroquine was A, ineffective in the management of COVID-19, and B, killed more people than it saved. Two papers were published by Surgisphere in the New England Journal of Medicine and the Lancet. And that's what they said. And that's when hydroxychloroquine use stopped. That's when all hydroxychloroquine experiments stopped. And then a few weeks later, in these two of the most prestigious medical journals in the world, both papers were retracted. Not because of some technicality, but because it was realized that they were completely fraudulent. The data were not there. They had made up the research out of whole cloth, as my legal advisors or my legal friends like to say, and they had to be withdrawn. And yet, people are still quoting those papers and using them as evidence as to why one should not use hydroxychloroquine. Anyway, this was completely unbelievable. It was as if the doctor was scientifically dyslexic. It's the exact opposite. So I can't explain it.
This is something that we see. This is a tactic that's used by the mainstream media all the time. Then this is actually how they control the narrative. They'll put out something they know is not factual, and there is no code of ethics in mainstream journalism at this point. I find that very, very limited. There's very limited people within mainstream journalism that still operate under a code of ethics, and they don't really care what they're putting out there because it serves a narrative. It serves a purpose, and even though it gets retracted or buried 2 days later, this becomes the talking point. This becomes the fact. This becomes the science. This becomes what Catherine McKenna quotes to the world. When you say it loud enough and often enough, it becomes fact.
Yeah. Look, I can't speak about the ethics of journalism. I'm not a journalist. But one thing that I do firmly believe is that even my physician colleagues who aren't offering treatment and so on, I don't think it's an ethical issue with them. I think they're being quite ethical. They took the Hippocratic Oath, and I think they believe in it. And I think they truly believe that they're going to harm their patients. Why, I don't know, but they truly believe this. And so I don't impute any nefariousness insofar as my medical colleagues is concerned at all. But on the other hand, I can't explain it. I don't understand why, when the evidence is there, it's right in front of you. All you have to do is delve into the literature. Don't just go to the CDC website. Don't just go to Toronto Health website. Read the actual research literature, including the meta-analyses, and everything becomes quite clear quite quickly.
Well, and this is where the censorship comes into this. It's the censorship and the silencing and the dismissal of meaningful discourse that creates this thought process or illusion of of unethical practices. Why do you not want me to speak if there's nothing to be afraid of, right? And this is a part of the entire envelope that Canadians seem to be stuck in is we have such a negative outlook on everything, because everything we're seeing from the mainstream media is fear, 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 fear. And we've got no meaningful discourse. Whether we agree or disagree is not the matter of point, but that we have to be able to have meaningful discourse so that people can make educated decisions. We need to hear disagreements, not silencing.
I agree. Well, you know, as I said, an infectious disease person responded to me after our interview in The Sun saying he was disgusted with the fact that I dared to express a differing opinion. It's very difficult to understand. And, you know, Peter McCullough, who is he's the most published person in the area of COVID management. He's the editor of 2 cardiology journals. He's a major scientist in medicine with a huge impact factor. And he drew a really interesting analogy, and I don't know if you've spoken to him at all.
No, not yet.
He's American, but he actually is helping with our group as well. And he said something really just hit home. He said, let's pretend you have a hospital room, and on one side you have a patient who's dying from COVID. On the other side of the room, you have a patient who has scabies, skin condition. Mm-hmm. And the person with scabies, you treat with ivermectin. No problem. They'll treat the person with scabies and the person will get better. Alternatively, the patient on the other side of the room who's dying from COVID will not receive the ivermectin to save his life. Does that make any sense?
No, it doesn't.
That in a nutshell describes what's going on, and I can't take credit for it. That was from Peter McCullough, but it was, I thought, a brilliant point to make, because it just made everything so clear, at least in terms of the lack of insight and logic that is associated with what's going on right now.
Well, in this confusion that's created out there, I spoke to this at the beginning of the lockdowns. I said, I think this is going to kind of backfire, because now they've got a captive audience that want answers, and now people are going to be spending endless hours digging through everything until they find answers. Today, I should say not today, but 13 months later, I have people sending me their pictures where they've been to the local vet clinic or to the horse barn, and they're showing me their boxes of ivermectin, because they figured out, enough of this out there to be asking and taking measures into their own hands, which is also a scary, scary thing.
This is also probably, actually, interestingly, HIV became a very politicized disease many, many years ago, for good reason, though. But in this case, COVID-19 has become a very politicized disease, and in particular, one of the first treatments recognized that would be effective, and on which there are many publications showing that's effective, hydroxychloroquine, was unfortunately mentioned by former President Trump. And as soon as President Trump mentioned that drug, that spelled the end of that drug. Whether you support President Trump or not, is irrelevant. It's immaterial. But it politicized the drug. I've never seen anything like this. And suddenly the drug became, or the use of that drug became verboten. And everyone did whatever they could do to show that it doesn't work. I can tell you, for example, and this is the political side of things, that there are papers that have been published in reputable journals, peer-reviewed, that have showed that, for example, the majority of papers that were published that showed that hydroxychloroquine doesn't work for COVID-19 are published in the United States, the vast majority. The papers that show that it does work are mainly published in Europe and Asia and other areas. Now, why is that? And it all happened, unfortunately, because of this politicized drug. And let me mention, because I've mentioned studies that show that hydroxychloroquine doesn't work. I can tell you that I've read those studies, as have others in our group, and they're terribly flawed. They, for example, studied hydroxychloroquine by administering toxic doses in patients. What did they learn from that? They learned They published. It was easy to publish because people wanted to publish it, as you could tell by the Lancet and New England Journal, which published fake studies. So it was published. And then you realize, well, they were given toxic doses. So, of course, they didn't survive. Not only that, what did they prove? Once again, that if you give toxic doses of a drug, it'll kill someone.
Yeah,
what
the
a surprise.
toxicity levels are accurate.
Some of the other studies, for example, were given to patients who were in the hospital on ventilators, and they were given hydroxychloroquine, and surprise, surprise, they didn't survive. Well, first of all, hydroxychloroquine is indicated for earlier treatment. Ivermectin can be used later on and early, but hydroxychloroquine typically is for earlier patient treatment, along with doxycycline, as has been shown, or azithromycin. And so they studied in people who weren't going to survive anyway. It's sort of like studying a drug in people who are half dead already. So that's another problem. Then they did another study where they looked at the impact of the use of hydroxychloroquine in an age cohort of patients who would not, from a statistical standpoint, had little to no risk of being hospitalized or dying from COVID-19. So if they already had little to no risk of dying from COVID-19, then how would treating them with a drug of any sort make any difference? And of course it didn't. These are designed to fail. It's sort of like using a drug to treat prostate cancer in females and saying, well, it doesn't have any effect on them. Or a drug to treat angina in 7-year-olds. Right. There's no effect. Oh, look at that. The drug's ineffective. It didn't change the incidence of angina in 7-year-olds. And so these studies, whether it was intentional or not, we don't know. Some people think it was, but I just say I don't know. But I do know, after reading the studies and not going to the CDC websites or the Toronto Health websites, that there was no way they were going to succeed in showing any positive effect. And then there's something called publication bias, which is if you don't show an effect, typically you don't publish, but not with hydroxychloroquine. If you don't show an effect with hydroxychloroquine, you easily get published. Same with ivermectin. Ivermectin is the new target for some odd reason.
Even though it's winning cases in court.
Yes, actually, you're aware of those cases where courts have had to order the use of ivermectin for patients who were dying, and doctors who were refusing to administer it for whatever reason. They got court orders. In one court order, the doctors actually defied the court order for another few days. This was in Chicago. I don't know how this particular patient is done, because they just kept delaying and delaying and delaying, and eventually she did get ivermectin, and I know that her oxygen requirement went down by about 30% within 1 day. So that she was showing improvement, but I haven't heard about how she's doing. That said, there were 3 or 4 New York patients who received ivermectin under court order. And they were given the ivermectin, and they were dying. And within a day or two, they were markedly improved. I think in one case, the patient was already out of the ICU in 1 day, off the ventilators in 1 day, and home feeling fine.
I probably have information sources that I go to, so and probably not all as precise or quotable as you do, but this is all the same consensus that almost anybody that spends time researching is seeing these same testimonials, the same information. Because I mean, typically that's kind of what we do. If we have a position on an argument or a discussion, we look for information that supports our argument, and there's no shortage of it out there. What there is a shortage of is addressing the confusion. We have all of these governing bodies, this, that, and the other thing, and nobody seems able to herd the confusion, to herd the discussion. Nobody wants to have the discussion. Public discussion is so. Where can we as the public put pressure on people to create more of that dialogue and discussion?
Well, I think we're doing it by doing this, by trying to get into the mainstream media, hopefully. I'd like also to point out, when in terms of people asking for proof, you will still talk to many people who say, "Oh, this is all anecdotal." Well, there are. I don't know if the audience understands what a meta-analysis is, but it basically takes several studies and small studies, let's say, because it's impossible to do large randomized control studies, which, by the way, in this population, I think would be unethical, randomized control trial in the COVID population. But they take these studies and they analyze the data and accrue thousands of patients in these studies. And there's some online live meta-analyses that keep taking up new papers, some of which might show no effect, most of which show positive effects of ivermectin, hydroxychloroquine, and other interventions, and there are several. And these meta-analyses, which analyze thousands of patients in terms of outcome, have shown very clearly that these interventions are highly effective to the tune of 70 to 80% reductions in hospitalization and death. And they're being ignored. And I can say that these studies have also shown that probably tens of thousands of people have died unnecessarily because we have withheld effective treatment, but my medical colleagues in this group can address that more accurately, I suppose, than I can. And it's very shameful, actually. And so we do have to get the word out. But the problem is that when we try to do this, we face arguments that are typically not based on fact.
Political.
Not based on data, and consist almost entirely of ad hominem attacks. It's fascinating. When you read negative comments about what we are espousing, they're typically ad hominem attacks. For example, where did you get this cracker? This crazy guy.
Yeah, it's an
this, that, right? But when you read opinions from people, let's say in the comments section of articles, who actually seem to support what we're talking about, first of all, the level of English language expression goes beyond the grade 6 level and is much more cogent, and they actually might come back with other data, either supportive or not. It's not always supportive. It's a very different way to look at things. And so we're faced with these ad hominem attacks, these attempts to destroy the reputations of people. I mean, Scott Atlas is a very well-known person in this field. The media tried to destroy his reputation. I don't think they succeeded, although they were successful temporarily, I believe. And there are others who've lost their jobs over this. Mm-hmm. But in the main, it seems that people try to destroy reputations. I fully expect that I'll be facing similar attacks after this interview. But as I said to you at the outset, based on what I've read, based on what I understand as a scientist and a clinician, I guess, I wear the criticism with pride.
Well, you're doing what we believe in and what we're trained to do isn't always easy, but it's always right. And this is when people are taking those steps, and like yourself, you know that this is going to be unpopular in some circles, and still being stepping forward and doing it. And this, I think, is the path to inspiring others. And since doing this, I've been so amazingly blessed with the overwhelming response from other doctors that they want to speak as well. They're tired of and they're doing the right thing behind the scenes, but they're also tired of being silenced and the vilification, and realizing, as you said, and this is what I see in the comments with having started this series, the comments are not all 100% in agreement, but the intellect level that is going into the commentary is exponentially greater than what it was even a month ago or 3 months ago, and this is incredibly encouraging to me, and the people that are seeking this out. So there's absolutely a thirst for people that will support you more so than people that won't.
Well, I certainly hope so. I know, I think my wife supports me, and pretty well.
That's a good start.
Because when I come home, the door is still unlocked. But if we don't say anything, when I say we, I mean maybe people who are farther along in their careers. I feel sorry for the young academics, the young clinicians. There's a very brave emergency physician. In fact, didn't you interview him out in Alberta? I think.
I haven't. I've only interviewed one from Alberta so far, Dr. Hodkinson. There's more coming.
There may have been another interview that I saw. A young, not that young, but an ICU clinician or infectious disease specialist. But he was at U of A, University of Alberta, and I don't know if he has tenure or anything, and he's really taking a chance. Now, having said this, this is what tenure was invented for. Tenure, which fortunately I have still, I think. Tenure was developed so that academics could express perhaps unpopular viewpoints. And I'm not saying that they could express lies and overt deception, because that's immoral and that's wrong. But telling the truth isn't wrong. And so it gives us the chance to go against the stream without fear of at least losing our homes and our livelihoods. And so I'm not nearly as brave as some of these younger clinicians and doctors and researchers who are coming out and saying that this is wrong, what's happening. But as I said, I got drawn in because of my research, and I just could not believe what I was seeing, and I couldn't stay silent. And I believe this is the same for a lot of the more senior members of the group. If we don't do it, the younger clinicians and the younger academicians can't.
Correct. And this is where throughout the course of these videos or interviews so far, most everybody that I've done initially here, and this is kind of by intent, have been people in your position that are tenured. You guys are good, or what you guys are expressing and sharing is going to be the foundation for these other doctors. And collectively, when they're hearing the people that trained them, taught them, that mentored them, that they trust, this is what's going to help them help themselves.
I think, I referred to George Orwell, but I think maybe even another better analogy is that the emperor has no clothes. And I think that everyone sees the emperor has no clothes, and that there is treatment available. We could end the pandemic now if that treatment were applied. And there are only certain people who I think can actually say out loud that the emperor has no clothes, and the others can't. However, as you, I think, alluded to, once people like myself, and more importantly, some of our medical experts and the people who really are on the front lines of this in terms of research and treatment, and have developed these novel and effective treatment modalities, when they speak out and say the emperor has no clothes, then the younger academicians, the younger clinicians, professionals will be less afraid to do so. I mean, as you said, the CPSO backed down. Mm-hmm. Well, why do you think they backed down? Because probably they got a lot of pushback from people who maybe even 3 months ago wouldn't have said a thing.
I wrote kind of a scathing piece on that when it first came out, and it was probably one of the farthest reaching pieces that I've written in quite some time, and it really expressed a level of outrage. And I think this was one of the things that attracted a bunch of these younger physicians now that have reached out to me, and that's over this past week. I haven't had a chance to interview them yet, but they're coming, and they are coming in droves because they want to be a part of the change. They are so tired of this, and just end this.
I have to say, the Royal College of Dental Surgeons hasn't made any pronouncements on this yet, and of course that sort of makes sense, I guess. But when I read that press release or that diktat from the CPSO, I have to say chills went up and down my spine.
Yeah.
When I read that.
Yeah, it was very disturbing to myself as well, and I kind of just stumbled across it through an alternate media platform, and when I read that, I had to stop and they do a double take. Did I really just read what I think I read? Because this sounds like it came right out of 1939 Germany. This couldn't have been a Canadian
No.
it couldn't be, right? So it was several reads later, I was like, okay, I have to write about this. I can't just do nothing. And interestingly enough, about 4 days after I wrote that, I know that we have a community here. They don't sit idle. And if there's an exercise that they can take part in, they do. And we have a fairly large demographic in Ontario, so I'm sure the college was hearing from some of our community. And I'm not saying or suggesting even for a second that had any input on it, but it did. I did see the Toronto Sun also come out about 4 days later with a piece scathing on them, and in that I'm sure had some impact. So this is where I think
I'm sure it came from various or many different directions. This Canadian group is one thing, but the Canadian group is also part of a larger international group of researchers and scientists. And I have to say that when one of us posted the CPSO, as I call it, diktat, the reaction from our US colleagues and EU colleagues was one of utter disbelief.
Complete
and horror and disbelief.
Yeah.
And interestingly, they used analogies of 1939 Germany, as you've just done as well, burning books and having opinions that only the state can tell you to have.
Well, when they start calling for the 2 minutes of hate, I'm out. Right? From Orwell's perspective, I think he was an optimist, and that was why what he did became such a phenomenal piece of work in history, is because he was able to tongue-in-cheek through several of his works, not just 1984, but create a story out of something in a tongue-in-cheek fashion, in an optimistic way, and kind of saying, look, guys, when you see this, it's time to pitter-patter and get at her. And that's what I'm seeing.
Yeah, using literary examples again, it's like Alice in Wonderland, 1984, and The Trial by Kafka, all wound together, which represents what I consider to be somewhat of a dystopic professional environment and public health practice and measures which make no sense. I mean, public health doesn't just include eliminating one virus. There's a lot more to public health than elimination of a virus. And I'm not saying, by the way, this is one bad virus. If somebody susceptible and has comorbidities gets this disease, they are in trouble. It's a nasty disease, but we can treat it. And if we treat it early, the chances are as I said, there's 75 to 80%, and some generally that level reduction in risk of being hospitalized and dying.
My personal opinion from a non-expert journalist is that we've gotten to a point where governments and officials felt they needed to look busy to do something, and this became a political event rather than a medical event. And once you get too far down the wrong path, nobody wants to turn around, and I think that's kind of where we're based.
Well, I think I agree with you there very strongly. To get a little political here, given what we've talked about, if the powers that be were to admit that they've been wrong about, let's say, lockdowns all this time, and that in fact the lockdowns are causing far more harm than saving lives, there are fewer deaths probably from COVID than are going to occur or have occurred as a result of the lockdown. And if they were to admit that, can you imagine the blowback? And that's an understatement that would occur. These people would be opening themselves out to God knows what, lawsuits, certainly losing elections. I mean, as you know, there are legal efforts afoot, initiated in, of all places, Germany. You mentioned 1939 Germany, but a very reputable, brilliant group of lawyers in Germany who are coming to Canada and the US to file class action suits, because the class action suits are not permitted in Europe, or at least they're not, they don't exist in Europe, and they're filing class action suits. So if the people that are recommending, let's say, zero COVID or complete and total lockdown, which disrupts livelihoods, kills millions, starvation, the whole thing, just read what the WHO said before they became more politicized. And if they admit that, they're in trouble.
And this is, I think, whether people like it or not, this is where we're going to be entering into a phase here of this, because the wheels are falling off of this bus, and we're going to be in a once the train stops, the train wreck happens, people are going to be looking for justice and accountability, and that's going to be a completely different socioeconomic situation for our country. And I don't think any activist, politician, or bureaucrat in any department is looking forward to this. So now they are kind of, now what? What do we do?
Well, that's why they're doubling down.
Yeah.
I mean, the best defense is a good offense, or deny, deny, deny. And so the best way to do this is to, instead of saying, maybe the lockdowns haven't worked because every time we do lockdowns, we still get infections. We get more infections, in fact. And when you compare lockdown countries with not lockdown countries or states in the US, you see huge differences in favor of the non-lockdown states. And, but maybe we'll just double down on the lockdown for now, because that shows that we're doing something for the people. My position on this is, I would like to see this virus disappear. I wish lockdowns really worked. I wish we could eliminate this virus, but that does not mean that we have to do something, even if it doesn't work.
Correct.
I mean, yes, we have to do something. We want to do something, but that does not provide a rationale in any way to support the notion that we should be doing things that not only do not help, but harm.
Well, this is my contribution to proving to the world that our politicians are science deniers. When we have enough of the leading experts talking about the science and not the politics and not the activism, this is how we ultimately get to that point, and realizing that day is inevitable. And this is unofficial yet for the world out there, but I'll drop this out here right now with you in appreciation. And one of the things that I've done is I've taken and started a task force with a slightly different outlook on things, and this is going to be realizing and accepting that people are going to need outlets for a soft place to land when they realize where we're going, when the truth comes out, and a path to accountability and justice, because we do not need society at large taking justice into their own hands. So people need to be prepared for that. And on that note, I have been reached out to from lawyers abroad, specifically Nuremberg. I have no idea where that is going to go yet, but for the audience's sake, they are watching. We are not alone in this, and speaking out like this matters immensely.
If I might say, I know we've said a lot of very perhaps frightening things or otherwise, but this is a good news story.
It is.
And it works. And anyone that denies it isn't reading the literature, period. Or they don't understand how to read a scientific paper, period. And it's a good news story.
It really is.
There is light at the end of the tunnel, and that light is very, very close. And if we just simply admitted that in fact there is available treatment as opposed to not even trying it. So when doctors tell me, oh, it doesn't work, well, have you tried it? Did you try it in anyone? Even have you read the literature? It's a good news story. There is treatment.
Well, it's always the darkest before the dawn. And I thank you for your outlook and your expertise today. This has been a real pleasure. And again, like I'm smiling. And a week ago, I would not have been smiling and having a discussion like this. But as you say, the day is coming. We are getting there. We are winning. And this insanity is unsustainable. That's one of my things. Insanity is unsustainable, and we're going to get there. So thank you so much for your time today. Is there any place where you'd like to direct people's attention to, or anything like that, before we head out of here? And give us your last thoughts for the afternoon.
Well, first of all, I appreciate you listening to me, and I want to reiterate that I'm speaking more as a scientist, obviously, than as a clinician. And there's literature out there they can read, and in fact, there's several publications or editorials, if you will, that we've published with Paul Alexander that you mentioned, that are on the website of the American Institute for Economic Research.
Yes, I have those listed, actually. Yes.
Yeah, and if you read them online, like, don't print them out. If you read them online, you'll see that they're linked to actual either research papers or perhaps news articles describing certain events. So they're referenced fairly well. Perhaps not to the level that I'd like to see in an academic publication, but this is as an editorial level publication. They're very well referenced, and I think your audience would do well to read the articles just as they are. Some of them are quite long and might appear to be repetitive, and maybe they are a bit. But at the same time, if they click on the links to the references, they'll see they're well referenced and make very good arguments for early outpatient treatment, and also outpatient, or not outpatient treatment, but early treatment of the elderly, which would have prevented untold numbers of deaths in long-term care facilities. And they would do well to read, I think, those articles. I think those would be very helpful.
Well, thank you for that. And for the audience out there, all of those articles are listed in yesterday's show with Dr. Alexander. So I concur.
We were, several of us were co-authors with this. Dr. Aksui, Dr. Dara, and myself were co-authors with Paul, who was the principal author. And it was a pleasure. Well, sort of a pleasure, I guess. It's sad that we had to write them, but it was a pleasure writing those articles with them. And I think your audience is going to find them very useful. So thank you again for having me on. I really appreciate it. And I wish you the best of luck in everything you do.
Well, I appreciate that. And I'm sure we'll talk again soon. So thank you for your time.
Thank you very much.
Well, there you go, ladies and gentlemen. Another wonderful discussion. A lot of great tips, information, and insight, and from people that know what they're talking about. So thanks for joining us here with this. Get these interviews are probably some of the most important work I've ever done, and this is going far and wide. This story is a long ways from over, but have faith, stay strong. Keep fighting. We will make Canada, Canada again. Stay safe. Bye for now.